Uh, Good evening, respected sirs and my colleagues. Am I audible, sir?
Yeah, you are audible. Yes, you are audible.
Okay. Uh, I'm Dr. Rajesh Sarachandani, Senior Resident in Department of Nephrology, RML Hospital. Uh, Today we are going to discuss a case of a patient, 30-year-old female. She is a resident of New Delhi, married since 10 years, but no children. Presented with chief complaints of on and off joint pain since 5 years, painless, palpable, non-itchy rashes since 3 years, reddish brown discoloration of urine since 2 years, and gradually progressive swelling since 1 month, with decreased urine output since 5 to 6 days. On examination, we found out that patient was hypertensive. Blood pressure at the time of examination was 154 by 96. Pulse rate was 98 per minute. With all peripheral pulses are well palpable, but pallor was there with facial puffiness. Pedal edema was there, and palpable erythematous rashes present over the both lower limbs. And right tunnel non-tunnel catheter was inserted. It was present, and on urinary examination, we found out that albumin was there plus 2, and RBCs was there. It was around 20 to 25 RBCs with some RBCs cast was also seen. And on further investigation, patient was found to be anemic, and it was normochromic normocytic picture with serum creatinine little bit higher side. It was 5.4, and that serum albumin was lower side. It was 2.9, and on quantification, 24 hours urinary protein was 1.6 grams. And regarding that ANA profile, ANA and dsDNA and C3, C4 was within normal limits. And regarding that anti-GBM, it was little bit confusion because one report we sent in our institute, it was positive, but it was qualitative report. Then we sent the outside report next day, it was negative and not significant. So another thing was ANCA profile I had done, it was negative. So after this thing, we had made a differential diagnosis of rapidly progressive glomerulonephritis. Most likely, it was small vessel vasculitis. Most likely, IG-related vasculitis. It may be cryoglobulinic vasculitis. Or as patient, she is a young lady, so we had made a possibility of lupus nephritis also with anemia. Most likely, it was chronic disease-related anemia with acute kidney disease was there. That was a dialysis requiring.
Okay. Have we completed the presentation?
Yes, sir.
Okay, but see, the differential diagnosis should come before your investigations, right? So you should think, then you do a certain investigation, then your investigations gets, you will rule out one by one. So, so she is a young female with history for the past many years, and she has been
Yes,
having
sir.
rashes, joint pain. It suggests as inflammatory joint pain, and she was having red-colored urine. You mean to say some amount of urinary? Is it red color or Coca-Cola color? Why or
Sir,
cola color? It's not
sir,
Coca-Cola. Cola.
yes, sir. Sir, it was reddish discoloration, sir. Sir,
Reddish discoloration for a young female, and
yes, sir.
it told that little bit raised creatinine with the creatinine of 5.4, isn't it? It's not
Yes, sir.
little
Yes,
bit.
sir.
I hope it's a 5.4 is a dialysis requiring renal shutdown. We say it is not little bit.
Yes.
I have just to correct it so that it's a renal shutdown. She is having a creatinine of 5.4 and with decreased urine output, probably volume overload, and you did biopsy.
Yes, sir.
So why
Yes,
did
sir.
you keep IgA vasculitis, like IgA vasculitis or cryoglobulinic vasculitis? Why do you keep
Yes,
this?
sir.
Why do you keep RPGN as a diagnosis, first of all?
Sir, because initially, within a weeks to months, that patient has a sudden decrease in urine output and increase in creat, sir. Matlab, within a few weeks, patient has renal shutdown, sir. That's why, sir, I had made a
So do you
diagnosis
have
of
the
RPGM, sir.
baseline serum creatinine?
No, sir, that was not available, sir. But before that, urine output was normal, and no, there was no any complaint. There was no swelling and no decrease in urine output, sir.
Is there any history of drugs like levamisole? Can you relate with these drugs? History of drugs which can mimic the vasculitis? Is there any history of
No,
drugs?
sir. No, sir. She had not taken any drugs, sir.
Okay, so why do you keep and the RPGN? So it's a GN, rapidly
Yes, sir.
progressive. So we have
Yes,
evidence
sir.
for GN in terms of proteinuria and RBC. And
Yes, sir.
what is the, why do you keep vasculitis as most likely etiology? Why? Because
Sir,
RPGN is also
because
found,
she,
yeah. So in RPGN, it
yes,
means
sir.
class 1, class 2, class 3, class 4, class 5. So which
Yes,
RPGN
sir.
do you want to keep? What is the class of
Sir,
clinical? Yeah. Although that is
sir,
pathological
most,
classification. Yeah.
yes, sir. So most likely it's the class two and a class three, sir. Most why I'm saying, sir, it was malab, we had made a diagnosis of vasculitis most likely because of IgA or no, maybe it because of lupus. That because of that I'm telling it is class two, and
Why do you
also, sir,
want vasculitis? Like, why do you want to keep vasculitis particularly?
yes, sir. Sir, because the rashes in this patient, it is palpable type of rashes is there, and moreover, more like, sir, it is on the lower limb, sir, mostly, sir, not on the sun exposed area, sir. So, with arthritis is there, sir. So that's why, sir, I had made a diagnosis of vasculitis, sir.
So in the vasculitis, you want to keep this immune complex, right? It's immune complex
Yes, sir.
RPGN. So it's
Yes, sir.
better to keep immune complex RPGN, out of which you want to keep
Okay.
HA related vasculitis, because lupus and all negative markers. If suppose if you have only clinical clues, this will be slightly down the list. You will be having lupus nephritis in the higher risk. Why do you want to keep cryoglobulinemia in this patient?
Sir, actually, she had rashes in the bilateral lower limb, sir. In cryoglobulinemia, we can also find this picture, sir. And also, sir, sir, that's why, sir, I had kept, sir. That is the reason. And
So this patient
C4,
had
C,
no history of blood transfusions, and your viral serology
no,
is also negative.
it's also
Hepatitis
negative.
C
Yes,
is
sir.
negative. Negative.
Yes, sir. It is negative, sir.
Okay. Okay, so anemia, you want to keep the chronic disease, that is the inflammatory disease which is going on. The acute
Yes,
kidney
sir.
injury is basically in dialysis requiring RPGN, which is dialysis requiring.
Yes,
Okay,
sir.
sir, do you want to ask any questions? Like a look, sir, from the clinical
Yeah,
details.
the compliments you said were normal, right?
Yes, sir.
So basically, what will happen if there is immune complex mediated proliferative GNA, at least one of the complements would definitely get depressed. Most likely,
Yes, sir.
not always the case. So even that you should keep in mind when keeping your differential diagnosis. So most of the time,
Yes, sir.
proliferative GNs will lead to some amount of complement conversion. So that's important.
Okay. Okay, sir.
So I don't know
Okay, sir.
the diagnosis. Let's go with IgA, you are telling, right? Let's see. Okay, sir, you can proceed. I don't know actually. I've not seen this case. Let's proceed, sir. You have any
Yeah,
pathological
I'll just
business?
check.
Yeah, yeah.
I'm very comfortable with this platform. Can you see the slides, sir?
No, sir. It is Rajesh slides is visible. Rajesh, we have to go with.
Sir, I have to stop sharing, sir.
Yes, sir.
Yes, sir. Yes,
Uh, are they visible now?
No, sir. Actually, it's not sharing.
Sir, just turn screen on. No, third tab from the right left side. Just on that.
The upper part of the screen, it is there. I think it's the
Yeah.
third. Yeah. Yes.
Yeah, yeah, sir.
Yes.
Does it come?
Yeah,
Yes,
yeah.
yes, sir.
Yes.
I can't see.
Yeah, yeah. It is
Yeah.
visible.
So now it's fine. Yeah.
Okay, now the slide is visible, right?
Yes, yes, sir.
Okay, so this is the patient Roshni, right? Because I don't have the sequence of your cases.
yes, sir.
Uh,
Roshni tissue.
Okay,
Roshni.
fine. Because I'll have to keep on cross checking. So this was the biopsy. So this is a low power view. You can see this is the HNE stain slide, and even at low power you can see these are large glomeruli, and if you look carefully you can appreciate some crescent like structures even at this magnification, right? And there is tubular injury. There's an RBC cast here, slightly more high power view. Now if you look carefully, this is the crescent, right? You can see it on the left hand side, and the if you look at the mesangial areas, you can actually see a lot of proliferation there. So there is a mesangio-proliferative kind of a morphology, and maybe a couple of cells in the capillaries. So there is an endocapillary hypercellularity. So there is a mesangial and endocapillary proliferative gene with crescents. So still higher power view, you can see the crescent. Maybe you can see this area. This is a necrotic area right at the 12 o'clock position, and the proliferation is very well visible here. Now this is a PA stained slide. You can see a circumferential cellular crescent, right? It's visible. And these pale areas, they are actually necrosis. So you can see this pale past negative area. So this is a glomerulus which is showing necrosis as well as a circumferential cellular crescent. Now this is the empty stained slide. These red things is the fibrin. So when you stain with Mason's trichrome, the fibrin appears bright red in color. So this denotes an area of necrosis, right? Now coming to the IF, it was interesting in the sense, now this is IgA. So you can see IgA very well in the mesangial location. So these are the stalks and the peripheral capillaries are negative. And so it's very 3+ to 4+ if you can call mesangial IgA. But that was not the end of the story. What we also had, when you look at IgG, it was actually linear along the capillaries. So this is the linear staining for IgG along the glomerular capillaries. So there are two things happening here. One is the mesangial IgA and the second one is linear IgG. So based on these two findings, we had a impression of a focal necrotizing and crescentic gene as we just now saw. And immunofluorescence revealed 3+ mesangial IgA and almost 2 to 3+ linear IgG. So they were coexisting. So now when you have this kind of a picture, there are two possibilities. So either this is an IgA nephropathy with an Oxford of M1, E1, S1, T1, C2, and maybe with a coexisting anti-GBM disease that needs to be confirmed on serology. Or even the converse can happen. So you can have an anti-GBM disease with coexisting IgA deposits. So these are two distinct clinical conditions with some amount of overlap in between and has been described in literature. And we also keep on seeing them once in a while. So in fact, we did a review of our data, and among our anti-GBM disease linear IgG, around 17% had coexisting IgA deposits. So it is something which needs to be investigated further in the whole scenario. Yeah. Were the images visible clearly?
It was visible, but what about the complement, sir? It is only. What about the complement?
Complement was only C3 was 1+.
Only 1+?
Only 1+. So IgA was 3+, C3 was 1+, IgG was linear along the GBMs, 3+, 2 to 3+, and kappa and lambda were almost equal. There was a little bit of lambda dominance as we see in IgA nephropathy, but nothing apart from that. C1q was negative and IgM was negative. So these were the two differentials which I said. So this is an interesting phenomenon.
Interesting, actually, because the clinical profile is different because she has been having certain kind of the inflammatory disease for years, but that has been predisposed with a very progressive course. Probably it's a crescentic gene, so crescentic transformation. But sir, with the absence of serological evidence of anti-GBM, it's telling that serologically anti-GBM was negative, but the sampling, what is the difference? What is the date of sampling between the biopsy and the?
Yeah, there are two things actually here. You actually had one report of anti-GBM, right? It was not that it was negative. So the point is the anti-GBM antibodies, they have a temporal profile.
Yeah, that's
so. Yeah, at one point they actually have a very unpredictable temporal profile. So, and the histology and the serology, this is often dissociated. So when the histological features appear in early stage, you often do not have the serology positive. And when it starts waning down, the histology stays on for a longer time and the serology becomes negative. So that is one part of it. What I suspect here, probably one disease has superimposed on the another. So that is the most plausible explanation for your duration of the disease. She might be having an IgNF. See, the reason I'm not calling it a anti-GBM disease right away is normally in anti-GBM disease, you do not get proliferative activity. You're not supposed to have. Yeah. And there was abundant mesangial and endocapillary proliferation here, which is not a feature of a native or an isolated anti-GBM disease. So there was definitely a proliferative lesion, which probably was an IgA nephropathy, and somehow superimposed on that, necrotizing crescentic GN occurred, which probably was anti-GBM mediated. So that can happen. Even if you look at the literature, you will find these cases. So there is a smoldering disease in some patients, and at one point of time they present with RPRF, and then you find the biopsy with IgA and linear IgG, and you actually have anti-GBM antibodies positive. So there's a very interesting phenomena which happens in these cases.
Sir, if it is an IgA predominant, the
Mhm.
C1, C3, 1 plus, like the complement, alternate complement pathway activation. So how do you see IgA with 1 plus, a 1 plus intensity of C3
Yeah,
in
so
this?
that's normal. So that does not indicate significant complement deposition in the kidney, because normally if you want to keep a differential of IgA dominant infection related GN, then C3 should be the dominant. So among all the immune reactants, C3 should be the dominant and IgA should be the dominant heavy chain. So that is what is the IgA dominant. But here we had IgA as the dominant, obviously, Miss Angel, and C3 was only 1 plus. So there was no differential diagnosis per se of a IgA dominant infection related GN. Of course, there was proliferation, but that can happen in an IgA nephropathy. And plus, necrosis is also an important sign. So necrosis is not a usual feature of IgA nephropathy
IgA nephropathy.
in absence of an HSP-like picture. So in Schwann purpura, of course, you get a lot of necrosis, but in absence of HSP-like clinical picture, you rarely get necrosis in IgA nephropathy. So necrosis again.
The crescents, what is the percentage of crescents, and was there in
This
the
was
similar stage?
100% here. This was all the glomeruli had crescents here.
Okay, so were there in the same age or in different?
Almost same age, yeah. Most of them were cellular, few fibrocellular, but almost of the same age. So you don't have that ANCA kind of a thing where you see. The point is ki when we talk about age of the crescents, it is important to remember all crescents start as cellular, right? So that is the basic premise. It is only the clinical presentation which will, at the point when you see the patient, will determine what is the different ages of crescents you are seeing. So in ANCA, because the injury keeps on happening, so you tend to get a, yeah. So that is the only difference. But if you look at both the diseases at one point of time, you will have cellular crescents in both of them. So probably that is correct in a given clinical scenario, but in this complex scenario, that particular thing won't hold good. But anyway, there were all cellular to predominantly fibrocellular crescent. So that again doesn't go well with the his long history. So this crescentic transformation is a recent phenomenon, definitely a recent phenomenon.
Yes, sir. That 1-2 weeks or 1 month with an cola-colored urine.
Absolutely.
I think there, but anti-GBM usually comes and hits and goes. The whole history comes in 2 weeks.
Yeah.
So probably
another problem with anti-GBM, I should tell you here only, there is a problem with the assay. Sometimes what happens, see, we have a specific domain against which we have anti-GBM antibodies to detect, right? And it has been in studies, it has been shown that around 20% of anti-GBM disease, that collagenous domain is not the one against which antibodies have been raised. So even though there are anti-GBM antibodies, you will not be able to detect them in serology because they are formed against a different domain of the collagen antibody. So this happens in almost 20% of cases. So you should not get worried if you don't get a serology positive, but you have the biopsy findings. So you have to trust the biopsy findings. Serology can come negative because of the assay problems which you can have. That's just the disease which can create confounding variables.
One of the other scenario can be like IgA was there.
Yeah.
IgA might have initially caused some crescents and that would have injured the membrane. Then that is causing antibodies.
Absolutely. So that's one of the hypotheses in these coexisting cases. You're absolutely correct. So what has been studied, it's all hypothesis, but this is one hypothesis. So proliferative variants of IgA nephropathy cause endothelial damage and expose the collagen. And anti-GBM antibodies can arise as a result of against the collagen antigens and cause an superimposed anti-GBM disease. So that's one of the hypotheses where you get both these things together. That's what.
Okay, nice case.
Yeah.
Yeah,
absolutely.
So it's interesting. Sir, actually, we have so many PG students here, residents.
Yeah.
So you can discuss the biopsies little more so that they can get more benefited.
Sure.
Like, okay, sir. Thank. So next case, I invite Dr. Sutanye. You can discuss on the next case.
Sir, my slides are visible.
Share your slideshow. So yeah.
Hello, sir. Sir,
Yeah, you're
sir, my
audible.
slides are visible.
Your slides are visible. You're audible, and
Sir,
you can show. You can
oh,
open the slideshow instead of
okay.
showing all the slides. You can start.
Okay, sir. Yes, sure. Very good evening to everyone, the faculty members and everyone present here. I'm going to discuss a case now. A 28-year-old male which presented with history of progressive body swelling for the last 4 months, which initially was started in the periorbital region and then progressed to involve the lower limbs and abdomen over the next 4 to 5 weeks. 2 months prior to admission, he also had progressive decrease in urine output, and there was no history of associated any fever, joint pain, oral ulcers, sore throat, or rashes. And subsequent to the starting of his problems, he had consulted a local doctor, and he was advised some Ayurvedic medicine for which he had taken for almost 4 months, and past history and family history was insignificant. So examination findings on patient on presentation was conscious oriented. His BP was around 140 by 90. Pulse rate was 86. And general examination had showed mild pallor and pitting lower limb edema of grade 3, and the systemic examination revealed ascites, and other examination findings were within normal limits. So we'll show some serial investigations of this patient. On admission, hemoglobin was 9.8, and subsequent reports were also in the same range. TLC was slightly on the higher side with an initial report of 13,800, and subsequent reports showed TLC of 11,000. Platelet was more or less within normal limits. Urea creatinine was slightly deranged with creatinine of 2 on admission, and the latest report prior to biopsy was 2.1. The patient had a very severe hypoalbuminemia of 1.8, and repeat report also showed that albumin was in the range of 2.2. Uric acid and calcium was normal, and calcium was the corrected calcium was also on the lower side. So urine routine microscopy showed 2 to 3 RBCs, and there was no RBC casts. Albumin was plus 4 plus. 24-hour in protein creatinine was 3.8 gram. ANA was positive in a titer of 1:320, and anti-TS DNA was also positive. C3, C4 both were on the lower side. ANA profile was not done as the patient couldn't just before the biopsy, the ANA profile was not done. ASO was negative, and ultrasound whole abdomen showed normal sized kidneys with increased cortical echogenicity. Following this, a renal biopsy was done, which was uneventful, and provisional diagnosis was membranous nephropathy secondary to lupus nephritis with superimposed AKI.
So then actually, so this is a male or female patient?
Male patient, sir. Male patient.
Okay, male patient with a history of 4 months, isn't it?
Yes, sir. History of 4 months.
Decreasing urine output
Yes,
with no RBCs in the urine. So why do you keep lupus
Yes,
nephritis as the first possibility? Don't you have no other differential diagnosis for this patient?
Sir, since the patient was having ANA positive of 1:320 titer as also anti-DS DNA positive, with both C3, C4 on the lower side, so that's why I kept lupus nephritis on the first diagnosis.
So why you are keeping class 5 lupus, that is membranous lupus? Why?
So no hematuria, like glomerular hematuria, only the nephrotic syndrome features were there, sir. That's why class 5, sir.
Okay, so usually the class 3 and 4 proliferative pictures usually have the systemic manifestations of
Yes, sir.
lupus, so it is also not there. So why you are telling it is superimposed AKI?
Sir, because one patient had, sir, prior to admission, patient had like a history of like Ayurvedic medicine intake, which might have caused a deranged KFT. Also, there was a superimposed AKI because the creatinine was 2, and the baseline, sir, prior just around the 2 to 3 weeks back prior to admission, it was at 0.8, so it had increased, sir. So either it can be due to the surge nephrosarca, or it can be due to the the superimposed effect of the Ayurvedic medicines he had taken, sir.
So there's no painkillers. Okay.
No
Suppose if
painkillers.
you don't have ANA and DSDNA positive for this patient, what could be your other DD?
So we can keep primary membranous nephropathy. We can keep FSGS also. We can keep MCD also, minimal change disease.
It's basically nephrotic presentation. Right?
Nephrotic presentations.
Okay. So they excluded CKD because there was a normal baseline creatinine.
Normal baseline creatinine, sir.
Yes, sir. Do you have any questions? Clinical question? Hello, sir. Sir, your voice is not audible. You have to on that audio. Yeah, your voice is not audible.
Yeah.
Yes.
So I'll just go along with when I present the slides. It will be interesting. Okay. Can I start now?
You can start.
Yeah.
Yes. Yes, sir.
So right. Is it visible now, the image? Okay.
Yes, sir. It's visible.
Okay, fine. So this was that biopsy. Can you just tell me then? Actually, I am not sure about which patient you are talking about. Okay, fine. So this, there are 4 cases, right?
Yeah. This is okay. Can you tell the patient
Sir,
name?
Patient name is Mojilal,
Yeah,
sir.
this is Mojilal. Okay. Fine. Just let me see once. Yeah. So this is the same patient. Okay. Interestingly, when we received this biopsy, we did not have the history of lupus nephritis. So we had to start from the scratch. But anyway, you can see this is the HNE stained image. So if you can look carefully, the capillaries are actually quite thickened. So at some places, right at the 12 o'clock, if you see carefully, you can actually see they are looking like some wire loop kind of thing. They're pretty much thickened. And some places you can see some mesangial proliferation, maybe some little bit of endocapsular cells here and there. But the overall picture looks pretty much like a glomerulopathy with thickened membranous like GBMs. Another area. So here you can actually appreciate a lot of mesangial proliferation also. These are the expanded. You can see, you can count the number of cells, almost 6 to 7 cells in the mesangial area, and plus the additional thing of thickened capillaries.
So can you tell where to see for mesangial proliferation?
Yeah. So see, if you look at this, first is you have to identify the stain, right? So the best way to identify the stain is to look at the Bauman's capsule. You can see the Bauman's. Is my cursor visible in the?
Yeah, visible.
Visible. Okay, fine. So this is the Bauman's capsule. So if the Bauman's capsule is not showing any particular color, you can assume that this is an HE stain, because what happens in PAS, the Bauman's capsule will start staining reddish magenta color. So this is an HE stain section. And then this is the hilum. So if you look carefully here, this particular area where my cursor is right now this is the afferent or the efferent arteriole, most likely. This is the hilum. So whatever is away from this, these are the lobules of the capillaries. And if you go farther there, so the area where my cursor here is the mesangial area, another mesangial area, another mesangial area, another mesangial area, and these are the peripheral capillaries, right? So this is where I was talking about, they appear pretty rigid and thickened. And normally the mesangial areas do not have more than 1 or 2 cells in their matrix. So if you find more than 3 or 4 cells in a mesangial matrix, it definitely defines as a endocapillary mesangial hypercellularity, provided your sections are cut at 3 microns. So that is a defining feature. So this is worth remembering. So if you cut thicker sections, everything will look like mesangial proliferation. So to actually judge whether there is true mesangial proliferation or not, you need those sections which are to be cut at least 3 microns. The lower would be better, but 3 microns is the ideal size. So this is the mesangial. And if you can see this reddish thing, these are the RBCs. So this is the capillary lumen of the glomerulus. So RBCs are within the capillary lumen. So if you start seeing any cells within these lumen, we call it endocapillary hypercellularity. So normally these capillaries are devoid of significant number of cells. They are empty most of the time. So any amount of cellular infiltrate in the glomerular capillary is abnormal, and we call it endocapillary hypercellularity because it is happening within the capillary loops, right? So this was another glomerulus. Now this is what I was talking to earlier. Now this stain you can identify. If you look at the Bowman's capsule, you can see that magenta colored lining is there, right? So this is a PS stain. In the PS stain, what happens? The mesangium becomes even more prominent. So what PS stain does is it stains the matrix components magenta red. So they stand out very well. So if you look carefully, even these areas, you can see count at least 5 to 6 cells here. There's some endocapillary cellularity also here. And these thickened capillaries are getting highlighted along with the expanded mesangium. So these are the tubules. My cursor here is at the tubular basement membrane. So even that gets stained with a reddish or magenta colored stain. And this is the tubule with it. The position where my cursor is right now is the brush border, right? You can see the reddish projections of the brush borders within the tubular. So these are proximal tubules. All of them are proximal tubules in this area. Now, IF, I've shown you a representative image of the IF because it is showing a lot of things here. You can identify two glomeruli, right? So these are the two glomeruli, and these bright green stainings, we use FITC as the conjugant. FITC is the fluorescent isothiocyanate. So it gives a greenish birefringence when blue light is incident on it. So that's why all the IF images appear green. So whatever is positive just shines up. So this is mesangial and capillary wall staining for IgG. This is the representative section. And this is what you are seeing in the, so basically what this stain denotes is immune complexes. So the moment you see this staining, you can be sure there is an immune complex deposition. Not only this, apart from the glomerulus, if you look carefully, what you're seeing here, this is a vessel. This is an artery, small artery. And just like we saw in the previous, these are the tubules, right? So in IF also, we can see these tubules because immune complexes are getting deposited along the tubular basement membranes also. So all these greenish thing which you see along the tubules are actually immune complexes. And this is a very specific and important finding when we talk about lupus nephritis. So extraglomerular, we call these extraglomerular immune complex deposits, which is a very important diagnostic feature or hallmark of autoimmune diseases, in particular systemic lupus nephritis. So we have a pan-compartmental staining here. So you have staining in the glomeruli, along the Bowman's capsule, in the vessel wall, and also along the tubular basement membranes. So we had an MCV. I just said in the beginning, we did not have the history of lupus. Had it been the history of lupus, I would have called it a class 3 plus class 5 lupus nephritis. Yeah. But now we are calling it membranous morphology with mesangial and endocapillary hypercellularity. DIF is full house with focal extraglomerular staining, which I just showed you. This is the extraglomerular staining. And of course, we call it likely renal involvement. But if you give us the history of SLE, we will call it a class 3 plus class 5 lupus nephritis based on the biopsy findings. So what actually biopsy, it is an important point to remember that biopsy does not diagnose lupus nephritis or SLE. It only classifies lupus nephritis when the clinical scenario fits in the case of SLE. So that is an important point we need to remember.
Okay.
Yeah, thank you.
Yeah. So it was a nice description. It is a nice description. So then, how do you treat this patient? Just on one line.
Sir, this patient was started on NIH regimen, sir. Patient was started on steroid along with cyclophosphamide monthly, sir. So he's, sir, at present he's doing well. Creatinine has come down to 0.7 last, and he has received the second dose of cyclophosphamide also. And swelling has also reduced.
Now, what makes you to give NIH than other therapy? Just okay, leave it. Why can't MMF? Because it's a young patient, you told. Okay.
It's a male patient, right?
Yes, sir, male patient.
So male lupus anyway is a...
People are, because it's okay, people are giving MMF. I do give MMF a lot of patients. That's fine. That's a clinical decision. Because MMF is not superior at least. And that's always good. Okay, so we will take another patient, sir. We will take the next case.
Sure.
It's from Vipul, Dr. Vipul. Yeah, sir, we have one question. Dr. Jeffrey has asked. Actually, probably she's preparing for. She's asking any of the other conditions where the full house deposits, including the complements and
that's an interesting question. Of course. So I'll you ask me one question. I'll give you one context-based information also here. See, almost all the proliferative genes, in the sense which show endocapillary hypercellularity, can give you a full house pattern, right? That starts right from MPGN to the infection-related gene, the conventional diffuse proliferative exudative gene, and of course lupus and other diseases. So full house positivity per se is not diagnostic of lupus. That is the reason I told you, because unless you put it in the correct clinical context, you cannot diagnose it. But proliferative genes like diffuse, any form of diffuse proliferative gene of any etiology, can be cryoglobulin or infection related gene, can show you a full house positivity. See, the full house positivity, basically we call it full house when you, the most important differentiator is C1q, right? So C1q is a marker of classical complement pathway activation. So in any disease, any proliferative disease where you have a classical complement pathway activation, you will always get C1q. And most of these diseases will also give you a full house positivity. So of course the prototype is lupus, but you can also get it in a conventional infection related gene. A lot of staphylococcal related genes also show a full house positivity because they activate the complement via the classical pathway. And another thing which you should know is, I just told you about the extraglomerular deposits, right? So lupus is one condition where you get these tubular basement membrane deposits, but there are 2 or 3 more conditions where we should be aware that TBMs can get stained. That is one of them. Important thing is IgG4 disease, right? So IgG4 disease is also an autoimmune disease where you can get ANA positivity, hypercomplementemia, but you get interstitial nephritis like picture, IgG4 plasma cells and deposits along the tubular basement membrane. That's one condition. Second condition where you can get TBM deposits is a ABBA disease. Have you heard about the anti-brush border antibody disease? It is a recently described disease in which you get antibodies against the brush border, tubular brush border antigen. That is a megalin. So when you have antibodies, circulating antibodies against the tubular brush borders, you can also have antibodies which are reacting against the tubular basement membrane. So you get a TBM basement membrane staining and hardly any glomerular involvement. So it's basically tubular disease with circulating anti-tubular brush border antibodies, called the anti-brush border antibody disease. So even there you can get tubular basement membrane antibodies. So these are the 3 important conditions where you get extraglomerular immune complexes. And if you come to transplants also, sometimes BK virus also elicits a localized immune response, and even there you can get deposits along the tubular basement membrane. So they can elicit an immune complex deposition around the sites of their replication. So these 3-4 conditions you should be aware of where you can get extraglomerular immune complex deposits. I think your voice is not heard, Dr. Muthu.
Dr. Jeffrey might be preparing for nephrology. I think Dr. Jeffrey, whatever sir has told is the context and the concept. Absolutely. When we come to a question, it's lupus, and we tell immune complex in HIV related HIV immune complex IVIC, and C1q nephropathy. C1q nephropathy. These are the 3 conditions where we will classically see the full house.
The only fortunate part is C1q nephropathy is very rarely proliferative. So you are in a safer zone there. So even though you have C1q deposits, it's most of the times a nephrotic syndrome. It presents unlike a proliferative gene.
Okay, so one more question is, somebody asked that it's a clinical question. Does full house pattern disappear after treatment of lupus? Yes, it disappears. We have now I started doing rebiopsies after 6 months, sir.
Oh, great.
So even 6 months.
Protocol biopsies.
Protocol biopsies, but as the treatment is same, we are not, till the patient achieves remission, we are not repeating the biopsy.
Absolutely.
In the patient who achieved clinical remission, and we do repeat biopsies, but we are seeing even with clinical remission, crescents are even there.
Yes,
even with clinical remission, actually. So we keep on giving them higher immunosuppression. That has changed our modality of treatment. We now give even rituximab also. We started in this patient, even membranous is doing good job. Actually, people think that in clinical remission, So that's why we tell clinical remission. There is
Actually,
nothing.
yeah, the criteria for clinical remissions are probably not sensitive enough. So
Yeah, so definitely, I have seen crescents in the patient with this, who is clinically
absolutely,
so many this thing. Yeah.
absolutely.
So this is interesting case discussion. Lupus with the full house and the extra glomerular stainings, like sir told, you should remember those things.
Absolutely.
And sir, have you seen any that anti-brush border? This is like till now.
Yeah. So we have seen, yeah, we have seen cases. In fact, you will be surprised to know that there have been case reports where anti-brush border antibody disease has actually presented in a patient with SLE and in another patient with lupus nephritis. So you have lupus nephritis, along with that you have an anti-brush border antibody disease. Both. So you have, obviously lupus, you have multiple circulating autoantibodies. So one of them could be an anti-brush border antibody disease, which will again present in a different manner. So we have seen, we recently acquired the antibody also for this. It's a very unique antibody which you have to put it up. But of course, we have seen a few cases ever since it was described about 3 years back, and since then we have seen approximately 10 cases since then.
Okay, sir. Okay, literature documented, sir.
Yeah, of course.
Okay, sir. No, you have like written that it's there in the article, like you have written, published, like.
Yeah, one of our publications in a large series includes one of the anti-brush border disease. We haven't published an isolated single case report, but there are 3 reports which are a part of a larger study. So they will be published as a big series of cases.
Okay. So it will be interesting to know whether this has any outcome on the is any differences in the outcome, like
the challenge happens
even
when,
in other
the challenge happens when it is the isolated disease. It doesn't happen with other autoimmune disease. Then it becomes a challenge to diagnose as well as to manage both things, because there are no defined criteria how to manage the disease basically.
Okay, next case, Preeti, can you start your presentation? Dr. Preeti.
Sir, so Dr. Vipul is trying to connect. Unko, I think voice issue हो रहा है. So I'm connecting through my phone and sharing his PPT.
Okay.
Hello.
Yeah.
Dr. Vipul.
Okay. So you can do that.
Hello, Dr. Vipul. आप unshare कर दीजिए.
Yeah, you can share that. If he is not there, I will present. No issues.
Hello.
Yeah,
Yes,
you
sir.
can share the screen. Yeah.
आपका स्क्रीन आप वो कर दीजिए. Right. हाँ, अनशेयर कर दीजिए, मैं शेयर कर देता हूँ. Right. कर दिया. एंड आप एक काम कीजिए, अपना मैं आपका स्पीकर ये ऑन कर रही हूँ, तो आप इसी पे. Sir, is visible now?
No, slides are not visible. Yes.
Hello.
Not visible. Yeah,
Not
slides
visible.
not visible.
Not visible.
Okay. Hello.
Okay.
Hello.
Yeah, it's. Yeah.
Dr. Vipul, you can speak now. Sir, a bit louder.
Hello. Am I audible?
Sir,
Yeah, you're
Dr.
audible.
Yeah, sir, Dr. Vipul, you can start now.
Good evening, everyone.
Sir, a bit louder.
Good evening, everyone. Can you see my slide?
Yeah.
So this is a presentation of a 34 years old female named Shivani who was hypertensive since last 1 year. She presented in our OPD with chief complaints of generalized swelling since January, on and off, which she was treated with diuretics, which she was taking on and off as per her symptoms. And she presented to our OPD as a referred patient in view of recurring swelling and rising creatinine.
Alka, can you show the next
Yeah.
slide?
Yes, sir.
On examination, the patient was stable with the positive finding included edema in bilateral lower limbs as well as she had in bilateral palpebral conjunctiva. Her BP was around 150/90 with pulse rate of around 90 per minute. On further investigations, the patient was anemic with HB of around 7.7 gram per cent. TLC count was 11,200. Among the KFT, the patient had urea of around 38.7 with creatinine importantly had a rising trend of from 1.2 in January to 1.54 in March to 2.9 in May, and then rose to 3.7 in June. The patient had proteins on lower side with 5.48 as well as hypoalbuminemia as 2.65. In the urine routine, the patient had 3 plus albumin with 10 to 12 RBCs. The 24-hour urinary protein was 3.5 grams per day. The patient had C3, C4, they were normal, and the ANA was negative. Based on this, the patient was discussed then over rounds and was planned for renal biopsy, keeping the credentials of IgA nephropathy as and second one was FSGS.
Okay, Upal, like, so you have not given any other history. Basically, it's a simple patient who have been referred for something and you did biopsy as the addiction was taken the rounds. But is there any, because we will be interested in knowing, is there any evidence of some history suggestive of connective tissue disease or
So there were no features like oral ulcers or hair fall or extra or articular manifestations like joint pains or anything. The only thing she
basically it's
had
a
was
hypertension with nephrotic presentation.
yes.
Right. When you give a differential diagnosis, first you have to tell the syndromic diagnosis rather than going into IgA nephropathy and FSDS. First, you have to tell what you think in the mind as a syndromic diagnosis. Suppose if you think nephrotic syndrome with hypertension, then our diagnosis becomes limited. If you think RBCs are not there, proliferative pattern, are you expecting a proliferative or nephrotic syndrome or a nephritic presentation? That's how the differential diagnosis started. So if I understand
Nephrotic presentations.
hypertension with nephrotic and the creatinine is rising. So the rising creatinine, what could be the reason for this? Is it? Do you think it's not? Can it not be an RPGN, or do you think it's an why is the rising creatinine happening? What is the reason for that?
Since the presentation was since January, it was around 6 months, and there was no investigations or any further planned biopsy for the same. The patient was being not treated for the real cause.
That is fine, but what could be the reason why? Is it crescents you are expecting? Is it the chronicity you are expecting for the rising creatinine? Is it AKI basically because of some other drugs? What do you think that? Is it
more like chronic rather than AKI?
Why are you telling it is chronic?
So the presentation was around since 1 year, sir.
Okay, so you want the chronic and the anemia patient. How do you explain this anemia for this patient?
Sorry,
anemia?
Yeah, she had anemia, sir, with HP of around 7.7.
That's what. So how do you relate this anemia with this patient? Right? What is the importance of this anemia?
What we do with the anemia of CKD or since she was a female and could be having associated iron deficiency also.
Okay, so you might have investigated for that now. So basically, you are keeping nephrotic syndrome with CKD. It's the probable cause of nephrotic syndrome. You are thinking either membranous or something like FSGS.
Right, IgA or FSGS.
IgA. So you're not keeping membranous. Okay. Why can't this be membranous? Okay, sir, you can proceed.
So right, so this was the biopsy. So as before, we start with the low power. So while looking at the biopsies also, we follow this procedure. So you start with the low magnification, just try to gauge how many glomeruli are there. The next step is just at the back of the mind, you see if there is any chronicity or any crescents or any proliferative activity, you can actually judge at the low power itself. So it's a very helpful tool when you actually go to the higher power. So this is an HE stained section, right? Same as we started earlier. So you can see this one single glomerulus here. And if you look carefully, even at this magnification, you can see there is some crescent-like structure here, and maybe some proliferation that we can see in the higher magnification. So it's not very well visible here, but definitely you can see there is one glomerulus which is showing some extracapillary cells around there. Now I have just included this image. This, if you can identify, this is a empty stain. So this Messen's trichrome stain, basically it has three colors, three components, and the most useful part in renal pathology is to judge the degree of fibrosis. So wherever fibrosis or collagen deposition occurs, the Messen's trichrome starts giving a blue color. So it's a very useful stain to judge the chronicity. In fact, it's the most useful stain to judge chronicity, and we rely, whatever percentage we give in our reports is predominantly based on appearance we see in this particular, the slide which is stained in this particular stain. So this is a Messen's trichrome stain section, in which all these blue areas which you are seeing, these are areas of collagen deposition. So you can see atrophic tubules, and in between them you can see a lot of fibrosis, signifying that this patient has a significant component of tubulointerstitial chronicity or fibrosis in its biopsy. And if you look carefully, this again is a blue area, right? So blue area means collagen. So this is actually a sclerosed glomerulus. So the collagenized glomerular tuft again will start appearing blue on the Messen's trichrome stain. And this is a tubular cast. So this is another tubular cast, and all these reddish things are proximal and distal tubules. Again, this is the higher power view of the same glomerulus we had seen in the first slide, right? So same glomerulus showing a, maybe it is not as cellular as we remember the last case. We had shown you one glomerulus with a lot of necrosis and circumferential crescent. That was the cellular crescent. Now what you are seeing here is a lot of pale areas. So pale areas denote collagenization. So this, you have some cells, you have some fibrosis. So this is a fibrocellular crescent. So there is a crescent because it is showing a moon-like shape. There are at least 4 to 5 layers of cells here, and there is a combination of fibrosis and cellularity. So this is a fibrocellular crescent. If you go down to the tuft, you can see, although it is compressed, see, when tufts get compressed, the judgment about the cellularity becomes compromised, because if you compress something, it will start appearing more crowded than it is. But even then, you can see that matrix appears slightly expanded, and you can see a few just about training your eyes, you can see a few neutrophils which are infiltrating inside the capillary lumina. So there is endocapillary hypercellularity as well. So you don't call it endocapillary proliferation. Do you know why? So there was a previous terminology in which we used to call something called as endocapillary proliferation. We don't call it proliferation because it is not multiplication of cells which are already there. So proliferation is when something is already there and it becomes more in number, right? So endocapillary hypercellularity denotes cells which are not normally present there. So it is not proliferation, it is hypercellularity. They're not supposed to be there. So mesangial cells, of course, you can call hypercellularity or proliferation because mesangial cells are normally there. So when they proliferate, you can call it proliferation, but not endocapillary. Endocapillary is always hypercellularity. Another higher power view of another glomerulus. Now here you can actually better see the features. So this is an HE stain section, hemotoxin and eosin. You can't really make out the Bowman's capsule as magenta or anything. This is the hilum. One arteriole is here, the other arteriole is here. So the arteriolar appearance will keep on varying depending on what plane you are cutting them. So these are transverse sections, right? So since it's a ball, 3-dimensional ball, the appearances of the arterioles and other things will keep on varying from one step section to another step section. So this section we can fortunately see both arterioles. They are very small, but you can still identify the hilar area here. So if you go away from the hilar area, this is one mesangial area, this is another mesangial area, this is another mesangial area. So you can see a lot of proliferative activities. So mesangial cells themselves are proliferating, mesangial proliferation. And in few areas, you can see cells within the capillaries also, like the one which I have just pointed out here. Even here. So this is even here. So this is endocapillary hypercellularity. So there is a mesangial and endocapillary cellularity. And if you look at 6 o'clock, there is also an addition. So this particular part of the tuft has actually gone and stuck up to the Bowman's capsule, forming an area of addition. So this is the sclerotic focus. It is not very well established right now, but with time it will become more and more fibrotic. Collagen will deposit and it will start appearing acellular. Right now it is appearing cellular, but slowly it will start becoming acellular. So this is the area of addition. So you have mesangial hypercellularity, you have endocapillary hypercellularity along with capillary additions, and we saw one crescent in the previous slide. Another area, this is past stain, so you can identify the tubular basement membranes and the Bowman's capsule, although this is disturbed because of the crescent. So this is almost a fibrous kind of a crescent here, very little cellularity, adhesions, mesangial matrix expansion, and increase in mesangial cellularity, right? So you have a mesangial and endocapillary proliferative glomerular morphology with focal crescent formation, increase in tubular interstitial chronicity. Now the next step is going to the immunofluorescence. Same image, you can see a lot of mesangial. This is IgA. So this is a mesangial IgA. So I have not put up C3 and other images, but this is what was the dominant immunoglobulin here. So the final diagnosis was an IgA nephropathy actually. So this is the Oxford classification which we commonly use nowadays. So M1 means mesangial hypercellularity, E1 denotes endocapillary hypercellularity, S1 denotes segmental sclerosis, T1 denotes tubular atrophy, interstitial fibrosis more than 25 but less than 50%, and C1 denotes crescents which are less than 25. So crescents meaning cellular and fibrocellular only. So we don't count fibrous crescents in IgA nephropathy classification. So this is less than 25% crescents is C1, more than 25% crescents is C2. So this is IgA nephropathy with mesangial and endocapillary hypercellularity, segmental sclerosis, moderate chronicity, and crescent formation. So this was our final diagnosis in this case.
So IgA presence, even I say that urine RBCs 1 and 2 also it matters because that can identify the proliferation.
Absolutely.
Because they give in the report nil or 1 or 2, 1, 2, 3 think as such less than 3 RBCs are normal, but I give importance to 1 RBC.
Yeah, absolutely. So yeah, actually it is very, yeah, who is doing the examination is also very important. So
very important. Yes.
And identifying dysmorphic RBCs should also be a important part of the curriculum, even for DM residents. I always insist on that. So if you have a bedside microscope, just try and identify the dysmorphism. So though just having RBCs isn't enough because they can come from the lower urinary tract as well. So identifying dysmorphic RBCs is not difficult. With practice, you can pick it up. So that is a useful skill to pick up even as a clinician on the bedside.
Sir, how many minimum glomeruli should be there to label this missed classification? So this question is for the...
See, the classification says 10. So 10 glomeruli are more than sufficient for if you have 10 glomeruli in a biopsy, it will be adequate to quantify most of the lesions. So 10 is the criteria, but we can't be too rigid in that. See, we shouldn't say that now there are only 9, I won't classify. That's not fair. So only when you are actually being jeopardized as to classifying it accurately, should you not use the classification. As far as possible, our effort is to classify it because that forms a very important baseline for future follow-up of the patient. So rather than going too much into mathematics, it's more about the overall adequacy of the biopsy and the disease process that will determine whether we are actually classifying the biopsy or not. But yes, of course, the recommendation is 10. That way.
Sir, we had one more case, but she could not come. So it's a nice meeting. Actually, I just want to tell about Dr. Alok for the other participants. Sir is there. Almost he has been having more than 2 decades of experience. And when I before start my curriculum in post graduation, he might be doing nephropathology, and he has had a maximum cases wherever you see in 10,000s. It will be. Can you tell, sir? Supposingly, like it's not like some just. Ratan, the other important thing is that sir is always sir is there for discussion. Actually, whenever I call, so he gives a call back that we are always
very important part of the relationship.
Yeah. As a clinical clinician, you are helpful for a clinician. So such kind of relationship is always necessary, particularly in cases like RPG. And I used to tell him, sir, that I want the biopsy tomorrow. I don't know why, how. And the rejection, if we suspect, we wanted it. So we were very kind to give the report as we required. And thanks for making your time possible.
Thank you.
And similarly, I would thank my residents and all the participants. We can take some questions. Before that, I also thank our Alka. She has been coordinating along with Noreen. So they are doing, this is my initial, because I think it takes around 20 minutes for a case discussion, sir. Yeah. So mainly monthly twice it is possible so that people will gain more from you. And
in fact, you can also have a basic biopsy interpretation class if you want, because that will be very useful for the residents. So that
But
before they actually start, because many times when you start just with the cases, that grasp won't come. So once you have some background, then it will become much more enjoyable. The whole process will become much more enjoyable.
okay, we will plan for the next for occasionally we can have 1 hour, 1.5 hours. Sir.
Yeah. Just
We
one
discuss.
class would be, then we can keep on discussing cases. Right?
Yeah.
It will be great.
Okay. So I thought like people will be writing their messages, so we have addressed whatever question they have asked. Norian, can you allow everybody to like to talk? Somebody we can take some questions if they want. On 10 minutes more, sir. Is it
Yeah,
possible?
absolutely.
Alka, if you can unmute the audience so they can take some questions. Somebody raises their hand. Yeah.
Right, sir.
Yeah. If somebody want to speak, like if they can ask questions. Yeah. So anybody do you want to ask any questions? Like, be glad for us to take any questions.
Sir, Shutana here. Sir,
Yeah, yeah.
Shutana here.
Yes.
Sir, how will you distinguish between primary and secondary membranous nephropathy on biopsy?
Okay.
Like, is it possible?
So this is an interesting question you brought up. See, in the last, you must have been following the literature all through. In the last 4 to 5 years, maybe we've had an explosion of antigens, right? So our concepts of primary and secondary membranous nephropathy have taken a huge hit. In the sense, previously it was just Platoir was primary and rest everything you had to start looking for secondary membranous gene. So the true secondary membranous gene has actually shrunk a lot. So you have true secondary membranous gene only when you look at the biopsy. See, biopsy wise, there will not be much difference on morphology, except of course when you have lupus. One of the cases which we missed out today was that of class 5 lupus, right? So that was one case where it is very important to be aware that biopsy alone, morphological appearances alone will not help you in deciding whether it is a primary or a secondary. Of course, with IF and other things, but you also need to be in touch and keep on applying the current knowledge also. So apart from mesangial proliferation, endocapillary hypercellularity, mesangial deposits, extraglommerular deposits, these are indicators of secondary etiology. So when you have a membranous biopsy which is looking like membranous, and you have a more than expected, more than G, you have C1q, A, then you start suspecting something is secondary. But that's not the entire truth. So since we now have antigens like exhaustocin where they can come positive, even exhaustocin associated membranous gene can show mesangial deposits. So those things have actually quite blurred out. So the ideal way to diagnose a membranous gene is to identify the antigen associated. So you have a Platoir associated membranous nephropathy. So you have a thrombospondin associated membranous nephropathy. We are not talking about primary and secondary. So if you want to call it, all of these are primary because they are associated with a particular target antigen, right? So similarly, you have NEL1 associated, you have exhaustocin associated, you have CMAT3. When none of these come out, of course, we have so many which are undiscovered, and you have a systemic disease like SLE or something, then you can probably think of a secondary, or he has an hepatitis B associated and nephropathy. Then you start thinking of secondary, but the biopsy findings will not always be indicative of secondary membranous gene. So it is not a game which can be solved on one side alone. You have to get together and solve the question of primary versus secondary. In fact, we have started doing the NEL1 exhaustocin and all. We just started doing a couple of weeks back, and you won't trust me. We started NEL1 3 weeks back, and we already have 10 positive cases of NEL1 associated membranous gene. So in the entire year, we have see only 3 or 4 thrombospondin positives. So we see around 1,500 membranous genes every year. So that's our volume. And of these, you rarely see 2 to 3 thrombospondin positive. But amongst the 200 odd membranous genes, we have seen Platoir negative, of course. Most of them have turned out to be NEL1 positive. So previously we would have thought that this is Platoir negative, this is thrombospondin negative, this is likely to be a secondary membranous gene, right? This is what our normal thought process would be. It is a Platoir negative. So we start looking for, but when you do an NEL1 antigen, it comes out positive. So it is a NEL1 associated primary membranous gene. So it's only about discovering antigens and putting them into clinical use that our understanding of primary versus so-called secondary membranous gene would actually move forward.
So then actually is so this is the context. The antigens are changing their definitions. I don't even call Platoir associated as primary.
Absolutely.
because it is a secondary now. So primary is which is prior to associated membranous. It's
Yeah,
not like primary membranous. We don't say primary because we don't know that. Then we told primary. The
absolutely.
floor 2 is not primary, I say. Because it is now secondary because we know the antigen, so we know how to treat that also. But we have less experience with exostatin and the NEL.
Yeah, so now as we started doing it, we'll get more. So it's
We
just
get more
about getting
experience.
experience. Yeah, it's just about getting experience.
So for Sutanya, for you, light microscopic finding, if something which is not proliferative, only thickening of the basement membrane with spikes, then it is primary. Usually it occurs in primary. Then secondary will have some, say, proliferation either in the mesangium or in the endocapillary, and you will have an IgG pattern, like immunofluorescence. We say in previous in primary membranous IgG4 will be dominant, but
Yeah,
in
that's an
secondary we will
important
get
point you have brought out.
IgO.
Yeah, absolutely. So IgG subtyping is a very important tool to decide upon that. So normally in primary or antigen associated membranous lesion, you usually get IgG1 and IgG4. So IgG4 is the most important one. So a lot of NL1 associated, but however IgG4 negative also. So that is not the only thing. But yes, of course, primary IgG4 if you get, think more in terms of a primary, less in terms of a secondary. That's very important. So in fact, in membranous lupus, you do not get IgG4. You get IgG1, IgG2, IgG3. IgG4 is absent even in a membranous, classical pure membranous lupus nephritis. You usually do not get an IgG4. So that's an important marker of primary nature of a membranous. Yes, definitely.
Thank you, sir. So we have one question from Arif, but what his question is like, throw some lights on different types of FSGS. What I say is, we will keep certain cases similar to an FSGS. Next time we'll put, when we discuss it, then it will be more useful. Otherwise, it will be a theoretical discussion with
Absolutely.
5 types.
Yeah.
And even then now, pathologists also don't say that there are so many issues with FSGS classification. And it's not the usual Columbia classification, which is
Yeah, I think the
managed.
Columbia classification is outdated. So for all
Outdated.
practical purposes, I don't think you should neither insist nor
Yeah.
follow that
Follow
classification
that.
because it makes no pathological or clinical sense. So every classification has a life, right? So classifications wane out and new ones come. So the Columbia classification probably has lived its life cycle. And with now our understanding, we'll probably follow a newer way to approach. Classifications are just approaches to a disease. They are not some God statements. So they will keep on changing. Even in your career, probably you'll see 2-3 more changes. So in everyone's career, you will come across 2-3 classification schemas for each disease. So now we are in this phase where FSGS, we have to leave behind Columbia, move forward with the primary versus secondary one.
Yeah. So we'll discuss more about FSGS in future classes.
Sure,
So,
absolutely. That will be wonderful.
if no other comments or questions are there, Alka, can we wind up the session with all your permission?
Yes, sir. Sure.
Yeah.
Thank you,
sir.
sir. Thank you, Dr.
Thank you for joining, sir. It's a
Thank you, Dr.
nice
Thank
session
you.
for me. We have been missing out of these academics for the last
Yeah,
1.5
absolutely.
years. COVID.
Yeah.
COVID has taken all the academics. So we'll just start with something. Let's see. So actually, Dr. Alok will be the person who can give the rarest of rare pictures in India. So students
of course.
can more,
We will keep
more
on sharing
inputs and
interesting
yes.
cases. Absolutely.
Yeah.
It will be a
Thank
pleasure.
you so much, sir.
Thank you.
Thank you so much.
Thank you, sir.
Thank you. Thank you. Bye-bye.